Our next speaker is going back to the topic of COVID and dialysis is Liz McNamara, who's the Chief Nursing Officer of the Northwest Kidney Centers, and she has a lived experience dealing with COVID in the dialysis setting and also has been a national leader in formulating policies. So great to have you, Liz.
I have to say it's been a long time since I've been in person, standing up a bunch in front of people, so this is probably my first in-person talk. Thank you so much. Jonathan, thank you so much for asking me to join you today. This is quite the auspicious group. So I'm going to take you back a little bit to the COVID-19 pandemic. Jonathan asked me to share my experience from the local, national level, and then how we're going to move forward. So I'm going to take you back to Friday, February 28th, 2020. It was 9 p.m. in the evening, and my cell phone rang. And it was my dyad partner, Dr. Suzanne Watnick. There was a patient at Evergreen Hospital in Kirkland. It was the first reported patient to have died in our country of COVID-19. Hadn't hit the media yet, so people will say it was the next day, Saturday. This was our patient. So this patient dialyzed at one of our clinics. We both said out loud, "This cannot, no, it's not possible." And then we remembered, because if you think back to that time, you couldn't get anybody tested unless they had traveled out of the country. Our patient hadn't traveled out of the country, but they had just uplifted the ability to test. So we quickly scrambled. We called our local partners. I can't say enough what Dr. Locke said about partnerships. So we're very lucky here in the city of Seattle is that we have one of the top public health officers in the country. We have amazing infectious disease at the University of Washington. We relied on our local partners and our national partners. So Suzanne and I got together. We were lucky that the clinic where these patients ran, it was about a week before that they ran, they'd been in the hospital for about a week, was closed on Saturday. So we had all day Saturday to sort of make some phone calls, figure some things out, talk to King County Public Health, talk to the CDC, and this is what we came up with our roadmap. So we believe that we had to honor taking care of patients in the outpatient dialysis world. Many organizations across the country at that time were putting signs up saying, "Go to the hospital if you have symptoms." We knew we couldn't do that. We wanted to lean into the science. I came from infection control world, so we thought what we knew about the virus, what we knew at the time, we knew we could do it safely. We wanted to use science and guide our principles. And we knew leadership was going to be critical. And I heard some of the patient panel, and we didn't do everything perfectly. We had to utilize direct organizational approaches. We had twice-a-day calls, probably for a good year, where staff could call in, physicians joined, people from other organizations joined just to talk. We had to be transparent. I think one of the things we said more times than not is it's really tough to be at the forefront of an ongoing pandemic. We had to evolve and change and be facile. And here's what we had to do. We had to support a lot of different people and educate a lot of different people, our patients, their families, our transportation drivers that bring our patients back and forth to dialysis, our staff, our physicians. We stood up our emergency operations center because the first two patients, now another patient died that weekend, was also from the same clinic, was also our patient. The CDC flew out because they didn't know where the nexus was. So we spent the first 2 weeks of March with a team from the CDC. They came to the clinic. They watched our workflow. They talked to staff. They interviewed patients. And it was then that we collaboratively developed the guidelines and principles that informed the country on how to safely take care of our patients in the outpatient dialysis with the COVID-19. I think to myself, could you imagine what would have been the impact on the hospitals if we hadn't done that? So this is me and my partner, Dr. Watnick. As you can see, I had dark hair. She was a little bit younger as well. And this is how we really felt. So I'm not going to tell you who's who, because we actually did exchange some gifts around this, but there we are. So then nationally, ASN, American Society Nephrologists, very quickly in March of 2020, spun up the COVID-19 response team. I'm honored to now be the co-chair of that COVID-19 response team with Dr. Jeffrey Zilverswag out of Rogosin. So 20 plus COVID-19 webinars, a COVID-19 webpage that to this day is still up and running and updated every week. We hosted weekly and every other week meetings with all the chief medical officers. So not just the nonprofit kidney care centers, every chief medical officer from every organization still meets to this day to discuss COVID, other things, whatever else is going on in the industry, supply chain, right? We helped each other out in those early days. We were about a week and a half away from being out of gloves back in the day, but we got help from our friends. Again, can't say enough about that. We have educational resources for the kidney community as well, which is a learning module, and we partnered with the CDC. What was super exciting is in March of 2021, ASN entered to a cooperative agreement with the CDC, and that work goes on today. We still meet with them. It's invaluable to have them on our team. Here's some of the resources that we're able to spin out. From the frontline perspective, it was nice not to have to reinvent the wheel every single time. Right? It was nice to have a standardized poster. That's the online toolkit up there in the right side. And that really helped inform. And the takeaways from that, I think one of the key takeaways is that nephrology has to be at the table. Nephrology has to be at these emergency operation centers, especially in the hospitals, right? If you think back to New York back in March and April, right? I mean, they had a huge surge. There's a lot of talk about ventilators, right, and the national stockpile of ventilators, but we were having issues with dialysate. They were having issues with machines. So we have to get out in front of the next surge so that we make sure that we can give the care that our patients need, and then the AKI population as well, which we saw with the first surge. So lessons learned from the pandemic, we took all the information that we heard and we really brought it into a learning module, and we're working on part 2. So this is just about ready to launch that we're super excited for. I can't say enough about the mental wellness. So we did the first module, and we realized there was a need for a second one. Some of the questions that were asked, and I was on the nurse panel, and it was really fascinating to actually walk through the questions. What do you see as the greatest challenge of coping with the pandemic? How's the pandemic influenced your professional plans and your personal plans? And how did you feel at your highest stress points? What's really fascinating as we go through this, I don't think we've hit the max stress point. I think what's happened is that this pandemic has gone on for so long, and now it's confluenced with the staffing shortages we're facing. Our hospitals here in Seattle, at least, and I know many across the country, are over capacity, right? We've got organizations closing dialysis clinics, condensing, closing chairs. Patients in the hospital can't get to SNFs. So from the leadership perspective and the frontline perspective, this has gone on a super long time, and now this is just a whole other layer. So this work that ASN has done, I think is really, really important. And I think as we move forward, each of our organizations is really thinking about how do we take care of our people, right? How do our employees feel as safe and well cared for at work as our patients do when they come to us? That's really the key. So we also realized leadership is crucial, as I touched on. Northwest Kidney Centers had the opportunity to be a beta test site for this work that ASN is doing, partnership with McNamara and Associates, which is really about you dive into how do you be a leader? What's it like to be a leader? How do you get to know your leader, right? So Suzanne and I had done this work, which was really imperative. We didn't have to necessarily get tripped up by team dynamics. We knew how each other worked. We knew what our styles were. We knew our strengths, so it didn't trip us up. Sure, it was still there, but it didn't trip us up. So I can't say enough about this work, and I'm super excited for other dyad partnerships to be able to walk through this. So I'm going to go back. Now I'm going to go forward. This is the phone. Monday, July 18th, 2022. Infection preventionist called me. A patient just called the unit and said, I have monkeypox. Can I still come to dialysis? So here's where we were. But what we had is we had the framework, and we had the partnerships, and we had the knowledge. So this is what we went back to, right? And we knew a whole lot more about monkeypox than we did about COVID-19. So we didn't have to say, oh, it's changed again, as many times as we had to do with the staff. So, I mean, I can't say enough about our journey. I'm honored to be part of the Northwest Kidney Centers. Although being the world's first dialysis organization, the first COVID-19, the first potential monkeypox, it's okay if someone else wants to be first. Coming up. But again, I can't say enough about the local partnerships, the partnerships with the University of Washington, across the nation. this small community has really led, and I think we've led very well, and we've learned so much. Again, we didn't do everything perfectly. We had misses. One of our biggest misses was we realized that we were having a disproportionate number of Latinx patients getting COVID-19. So we went back, and we realized we didn't do a good enough job with education using translators. So data driving what we do and what we didn't know, we have to ask ourselves that, because we know we weren't perfect. But that was the beauty of it. So thank you for letting me share my story. I know it was a little lighter than the previous talk. So but have a great rest of the conference. Happy to take any questions or comments. And I think I got you back on time, Jonathan. That was my goal. Thank you.
Any questions?
Thank you, Liz. Thanks a lot for the leadership. One of the things you reflected on, and I think we heard from the panel this morning, is that they, in other parts of the country, had dialysis facilities who had disaster plans, and they fell apart in face of the disaster. Communication plans, typical. In the middle of a disaster, you have a great communication plan, falls apart. What are we doing not only here, but throughout the rest of the kidney community? What can we do in innovations so that when the next disaster comes, because it's coming,
Yep.
and it might be climate related, and it might be disease related, and it might be funding related. What are we doing so that it won't fall apart? Because our patients deserve that, and they're going to be vulnerable. And what are we doing?
Yeah, I think it's the leadership that's the key, right? Because as leaders, you have to do your own work so you can lead, right? What we did for our staff is we sourced things that they couldn't get at the time, right? We bought toilet paper and cleaning supplies and left them in the clinics. You had to take care of your house. We wanted them focused here. And I think don't forget the low technology stuff, right? We didn't spin up Zoom calls initially. Nobody knew how to use Zoom. We did phone calls. And we were present. We were present with the staff. We were open and honest. And we were incredibly transparent. So I think what happens when a plan falls apart, it's because everybody is anxious and doesn't have the tools they need to do their job. So I think the preemptive, and then we've also talked about tabletop drills. What went well, what didn't go well. You have to debrief that. I mean, if you've got a clear, solid plan, you should be able to pick it up. But I think what happened was everyone was uncertain at the time. The staff were uncertain. The staff were afraid. I don't want to take care of these patients. I could get it. I could give it to my patient. So it's really that partnership. I think the other thing that had happened locally is that ASN and the CDC and the HHS all met routinely to talk about the plans and what was going on. So I think that's key, is every level of our country system needs to be partnering with their partners. I hope that answers your question. Thanks.
Steve Ash. Nothing increases anxiety like seeing a theoretical problem become real, such as this infection. And patients would look for obvious answers. And I think a lot of patients thought, why can't I do dialysis at home? Did you find that, and how did you capitalize on it? Did you find an increase in your interest and success in peritoneal or hemo at home?
Yeah, we did. That's a great question. Thank you. We went from about probably 14, 15% of our patient population dialyzing at home to a little over 18% right now. And I think, again, what we did well is that we built an infrastructure with our home program with different layers of nurses, supervisors. Again, it's the people is the key, right? We have to keep the people there. And I think that's how we've been able to spin it up. We still do urgent start PD as well. And I think the other challenge with PD, especially when we saw across the border, is that a lot of people were starting AKI PD in the hospitals, right? Because they didn't have enough machines, but then they couldn't do it at home because the AKI isn't paid for in home dialysis right now in this country. So that's another thing that's on our list for the government. So thank you for the question. Thank you, Jonathan. Thank you so much, everybody.